We're sticking with the cardiology theme, and I'm pleased to introduce next Dr Katherine von Klemperer, who leads the cardiology team who work with the London EDS service. Dr von Klemperer, she's going to talk to us about antenatal considerations in vascular EDS.
Thanks, Glenda. It's nice to hear another South African voice this far north. I've got the task of talking about vascular EDS and pregnancy today. As I'm sure you're all aware, and as we've said this morning, vascular EDS is a very rare condition. And as a result, a lot of the cases in the literature and the reports on pregnancy are based on patients, many of whom actually didn't know they had the diagnosis when they were pregnant. And we've got very little prospective data, so data following women who are known to have vascular EDS through pregnancy. And there are very few people who I think would consider themselves experts in this area. And so what we have to do is what we do in a lot of other conditions, cardiovascular conditions in pregnancy, and that is we have to apply a very practical approach to the woman with vascular EDS. In order to be able to preconceptual counsel her and to manage her through pregnancy. So how do we approach this? Well, the first and certainly the most important is to know our patient and know their partners and their support system. We need to know the physiological change of pregnancy and the challenges that our patient is likely to come up against. We need to know the literature as best we can, and we need to know the risk as it is presented to us in the literature. And we need to know what drugs we can use and how we should follow people up as safely as we can, and how we should deliver them as safely as we can. So for some reason my text's gone small on know your patient, but actually know your patient is definitely the most important thing here, so we tend to really get as much history as we can from our patients who are wanting to fall pregnant in terms of knowing their medical condition holistically, because pregnancy affects all of the systems, the body systems, and so we need to sort of think about the team that the patient's likely to need. We need to update our imaging as much as we can. And then we also need to know their support systems, we need to know their partners, and their partners need to know us and their condition. We need to also understand their views on risk, their ethical views on things in general. The next thing we need to do is understand the physiological change that might happen in pregnancy. And Nigel's been through very clearly what happens in blood vessel walls in the non-pregnant state. In pregnancy, there's a doubling of blood volume by the time you get to the third trimester, and 1 in 6 women will have a hypertensive condition in pregnancy. So those are things we need to think about and anticipate. And we also know that there's quite significant change in connective tissue in pregnancy, so the hormonal change affects the connective tissue, so everything becomes a little bit more relaxed, and that's just to cope with the more blood volume in the blood vessels, to cope with the pregnant uterus, the muscle of the pregnant uterus relaxes, and there's some changes that happen at structural level. And also the joints become more lax, and this is all just to sort of accommodate pregnancy essentially. We know that simple things happen in pregnancy, so women tend to get more worsening of their varicose veins, and things like constipation are quite common. Anticipate all these things. Then, as I said, the next step is to look at what we do know about pregnancy from the literature that there is out there. And the literature that we have is pretty dire, if I'm honest. A lot of the literature is based on case reports, so it's patients who've had catastrophic outcomes as a single case report because good news doesn't sell headlines. So often those are the stories that make the literature. And it was until 2014 that we had a sort of reasonable collection of patients to look at in terms of outcomes. And it was this study by Peter Byers that you'll see on the Annabelle's Challenge website, and this is the study that we tend to refer to when we quote risk in pregnancy. And what they've done in their study is they've had two approaches. The one is they've looked back at retrospectively at their pedigrees, so they've looked at all the family histories they've taken on their patients with vascular EDS, and they've looked through those and they've worked out, looking back, in those women, in the women of childbearing age, they've looked at those who had pregnancies and those who didn't have pregnancies, so that they had a control group to compare to. And they have looked at around 600 deliveries, and in that group of women, just looking back at that pedigree, they've noted that there were 30 deaths in 616 deliveries. So that's a 5% risk of death in pregnancy just based on that retrospective study. I would say that prior to the study of theirs, we were quoting risks of 25% to women with vascular EDS. The second part of the study that they've done is they've sent out a questionnaire, and they've asked people or their relatives to fill in a questionnaire with much more specific questions so that they can get more of a feel of what actually the complications are, when they happen, and why they happen. And when we look at that questionnaire, which was only filled in by 38 people, so again, this is small data that we're talking about, they've noted that 10% of women had cardiovascular complication in pregnancy. Most of those women, interestingly, were women who had gone 2-term in pregnancy, which is just because, as I've said, most of these patients didn't actually know they had the diagnosis when they were pregnant. So there were quite a few vessel dissections in their data, and there were also 2 uterine ruptures. As Debbie said, they're relatively rare, bladder and venous tear during the cesarean section. But there's quite a lot of preterm deliveries, so 1 in 5 of those deliveries were preterm, and not necessarily because clinicians were delivering them early, probably more because perhaps their babies were affected. And there was a high incidence of 3rd-degree tear, so tear through the vagina and sometimes through right into the rectum. And those tears in our patients with vascular EDS can be really awful because the healing is so difficult afterwards. So that is not an inconsequential complication. And there's also a lot of hemorrhage peri-delivery, which there's in everyone, but obviously with vascular EDS there's much more propensity to that. In that series, in those 38 women, that questionnaire, they had therefore showed a 50% major complication, as the Sheffield team are reporting they're seeing, and there were also 6 deaths, and 1 was due to cesarean section wound coming apart, but the rest were due to vascular events, which is not a huge surprise to us as cardiologists looking after women with aorta vascular problems, because the risk of dying from a dissection or a tear or a rupture of aorta in pregnancy is well over 30%. What they did interestingly show is that despite this sort of relatively high risk of events, they didn't see any difference between in long-term mortality of the women who fell pregnant compared to those who didn't. It needs to be taken with a little bit of a pinch of salt, because it may well be that the women who didn't fall pregnant were warned against it or chose against it because they'd had sort of previous complications or were less well than the women who did embark on pregnancy. Did it give us any further in terms of being able to risk stratify patients? Well, not really. The only thing it showed is that if you've got a null mutation, which we've been referring to this morning, there seemed to be a less of a chance of having severe complications in pregnancy. They did show that having had a previous successful pregnancy didn't mean you were going to be fine the next time round. They had actually one woman who dissected on her 7th pregnancy. Because this data wasn't prospective, so because it wasn't following people up who we knew before, it doesn't tell us whether having any underlying vascular pathology puts you more at risk. When we look at the confidential inquiry into maternal mortality in this country, cardiovascular disease remains the highest, the sort of primary cause of maternal death, and 1 in 6 of those women who die in pregnancy in this country die from aortic dissection. And that's because, unfortunately, as clinicians, where we can help with a lot of things in terms of cardiovascular support, so if we've got people with bad pump function, we can support that. If we've got patients with bad valve disease, we can manage that. But we're not very good at managing problems with the aorta and the blood vessels, and we're also not very good at managing problems when people do dissect. So this is a condition, aortopathy and aortovascular conditions are every maternal cardiologist's nightmare, to be honest, and it's just because it's so unpredictable. And so it's probably no surprise then that the European guidelines for cardiac disease in pregnancy consider vascular EDS an absolute no-no, so they put it in class 4, which is very high risk. The recommendation is to, sorry, my slides are a little bit messed up, but the recommendations are basically that this is high risk and pregnancy is contraindicated. If someone falls pregnant, you should talk to them about termination. So, how do we approach things? Well, the first and the most important thing is preconceptual counselling, and it's important that that starts really young. So you can see here that in the bias data that actually quite a lot of women are falling pregnant before the age of sort of mid-20s, and so we actually need to start talking to women with vascular EDS or girls with vascular EDS about the risk of pregnancy quite early, which is always a difficult challenge, to be honest. When we have preconceptual counselling, we need the patient's partner present to make sure they're aware and on board. We need to gauge the couple's understanding of their own condition. We need to talk about the risk to the woman, as we've understood it, and the risk to the fetus. And it's at this stage that we probably need to bring up the conversation about options for the fetus again. So most women will have had some form of counselling about this when they got their genetic diagnosis, but it's important to reiterate it at this stage. Pre-genetic diagnosis, which I'm sure most of you are aware of, is an IVF pregnancy, where basically the woman is given hormones to stimulate egg production. The eggs are then retrieved and then fertilized with the sperm of the partner in a petri dish, essentially, and then reimplanted. And then the embryos are genetically assessed, and only an unaffected embryo is reimplanted. And that process is thought to give 98% protection against the baby, against a baby having vascular EDS. PGD in this country has quite strict sort of limitations, so it has to be done before the age of 40. This is on the NHS. You have to have a BMI between 19 and 30. You have to be in a stable relationship, and basically you have to have a known gene, which has been done in this country, and be a non-smoker. And if you've already got a healthy child, then PGD can be available to you, but it won't be funded by the NHS. Because of the risk category for vascular EDS in pregnancy, there's been a lot of hesitation about PGD for our patients with vascular EDS, and particularly of late. These pictures are a bit like Jared's back of cigarette pictures. They're just me taking snapshots off the screen, so I apologize for the quality of them. But you can see here that this is the form that we're now having to fill in for our patients with vascular EDS considering PGD. And the PGD teams are essentially looking at whether women have any underlying vascular abnormalities, any intra-abdominal abnormalities or abdominal pathology, and so they're looking sort of at quite specific things, and they're taking each case on at the moment on a case-by-case basis, which they're considering a sort of pilot study, because we've been pushing that we think our patients should be eligible. For patients where PGD isn't an option, as Deborah mentioned, there's the option of diagnosis in pregnancy through chorionic villus sampling or amniocentesis. But all of these procedures do come with a small risk, and I suppose the problem with making a diagnosis in pregnancy is you need to be clear in your head as a woman about whether you would want to have a termination of pregnancy if you found out that the baby's affected. So after we have been through all of these points with our patient and their partner, we need to talk about what pregnancy and surveillance would look like. Logistically, this can often be quite difficult. A lot of our patients travel quite a long way to see us, and so it's not really practical for our patients to necessarily be followed up in the tertiary centres where they're looked after, and so often there's a lot of liaison that has to go on with peripheral teams. Medication changes also need to be made once decisions are made. So in terms of medication changes, Professor Wilden was speaking about the sartan and sartans, and they're teratogenic, and so we would tend to get women off a sartan before she fell pregnant. And then we need to look at the other medication and see if there's anything else that's not fine for pregnancy if they're deciding to go ahead. And obviously there's also the thing that if women decide at that stage not to go ahead, we need to counsel about good contraception. Management-wise, the main sort of approach of management is just that we really need to protect our patients and their babies as best we can. We need to make sure they've got optimal access to a team, understand their condition, and we need to educate. So if you think general clinicians have hardly seen this condition, you can imagine how many midwives have. And so it's, the whole way through the pregnancy, it's a case of education. As I said, logistics can be difficult. We certainly recommend women carry on their beta blockers. We use beta blockers like Smarties in pregnancy for all sorts of other conditions, and I firmly believe that they absolutely are safe. And then we need to think about surveillance based on the underlying pathology of the patient. And there also needs to be fetal surveillance, particularly if we think that the baby might be affected, and there may be some clues to that on fetal surveillance, like sort of seeing things like clubfoot. Delivery planning. Delivery planning is tricky. As you can see from the graph here, from the BIAS study, less than 50% of women had no complication around the time of delivery, and that certainly is the time we see people running into trouble. Anesthesia can be difficult. The spinals and epidurals can be complicated in a patient with vascular EDS, and we need a very careful spinal assessment if we're going to go down that route. We need to anticipate bleeding, and basically we have to have a very careful delivery plan, and there's often, as Glenda noted, a lot of phone calls that take place and a lot of emails that take place around our patients. So we observe them closely postpartum. We consider postpartum imaging. There's been some recent data suggesting that in Marfan mice that breastfeeding might be a problem, but I don't think we have enough data on that yet, and we're not talking about Marfan syndrome here, and we're not talking about mice, so I think we need to take it all with a little pinch of salt. And I'm just going to finish now, and I don't know if you can read this, but this is just a post from a woman with vascular EDS. It's a really beautiful post, and really sort of highlights a lot of the problems and challenges for women with vascular EDS. But I think what she's said here is that they are just living the best lives that they can, and so I don't think that it is correct to say that women with vascular EDS shouldn't fall pregnant or should terminate. I think it's really important that everyone's informed, and I think it's great that we have such a sort of big sort of group of people attending today. I think it's something we all need to keep talking about, and we need to try and support as best we can.